This is a paradigm shift when it comes to how we think about treating LDL cholesterol. For years now, we have been treating hypertension and diabetes with early aggressive combination therapy, with the idea being that by hitting the targets with multiple different agents from different classes, you're more efficiently getting to your target and you're doing it with fewer side effects. But in the world of lipid management, this is really the first time we're considering this type of concept. Of course, we always want to start with the statin kind of as a foundational lipid lowering therapy. But very soon after you initiate that statin and maximize the dose, you want to reach for combination therapy with lipid lowering agents from different classes as necessary to try to get you to your thresholds a little bit faster and to try to get you there with minimal side effects. So in general, if you're more than 20% away from your ASCVD threshold, whatever that might be for that particular patient, you don't want to just give them ezetimibe, wait, and waste time, because all of that time is cholesterol years of exposure, cholesterol time of exposure to this endotoxin that you're wasting. So you really want to try to get them on combination therapy. In fact, now in many countries such as India and in Europe, they're using combination therapy up front at the time of an acute coronary syndrome in order not only to get patients to their target faster, but to help really suppress that angry plaque. Because remember, an acute coronary syndrome is a result of an angry plaque. So using multiple agents from different classes after a statin, and now the good news is we've got so many agents in our lipid lowering toolbox, really will help you maximize how you're treating your patients and help you get them to their goals faster. For the longest time, we've been talking about cholesterol pack years of exposure. So we take the number of packs you smoke, multiply it by the number of years you've been exposed, and we really talk about how that, irritates the endothelium as a toxin. That's the exact same concept when it comes to LDL. It's cholesterol years of exposure. So it's what your cholesterol is multiplied by the years of exposure that really determines your endothelial and vascular risk. And so the idea here has become that for many decades, we were sort of ignoring mild to moderate hyperlipidemia because we thought it was a threshold effect. We thought you had to be severe enough in order for it to trigger vascular inflammation. But even mild to moderate hyperlipidemia with this endotoxin, which is LDL cholesterol, over many, many years can confer risk. And if you think about the breakdown of how this works, in a way, cholesterol exposure early in your life is actually more toxic to the endothelium than cholesterol exposure later in life, which is why we see this naive endothelium almost being a little bit more sensitive to that cholesterol exposure. So we are starting now to shift the curve of that cholesterol years of exposure to try to flatten it early in your life or aggressively after an acute coronary syndrome to really minimize and reduce the risk. And so whenever we see our patients, even if it's for primary prevention, we really want to think about, their genetic predisposition for cholesterol, how long it's been elevated, and what that area under the curve is, because that's what causes that endothelial activation. There's something certainly biological about statin intolerance that we don't quite understand. And we know that it tends to occur more in women than it does in their male counterparts. And that's a testament to the fact that the CLEAR Outcomes trial enrolled 48% women. And it's the only sort of cardiology trial that has such a high representation of women because it was seeking the phenotype of the statin intolerant patient. Now, we don't quite understand what those biological, physiological, and hormonal mechanisms are for creating that statin intolerance in women. But knowing that we have that, the CLEAR Outcomes trial really does sort of create a new benchmark for treatment of these patients. And for the longest time, I call them the forgotten children of cardiology, because we really didn't have many options. And if people were statin intolerant, and you couldn't get a PCSK9 monoclonal antibody approved because they were not in a secondary prevention cohort, you're sort of stuck. You left them untreated, really, with those that endotoxin LDL really remaining unchecked. But what that CLEAR Outcomes trial showed us in the statin intolerant phenotype, and mind you, this was the first and only randomized trial in a statin intolerant phenotype, is that you can reduce these people's events by putting them on lipid lowering therapy, and there are alternative agents. Now, one of the criticisms of the CLEAR Outcomes trial was that the on-treatment LDL continued to to be significantly high. So even though you got it down and you reduced major adverse cardiovascular events, you didn't get it down enough with just bempedoic acid. So for me as a clinician, I'm really going to be reaching more for that combination medication, bempedoic acid plus ezetimibe, when it comes to my statin intolerant patients, really thinking about, again, novel mechanisms to interrupt cholesterol homeostasis and change your cholesterol levels, but really using combination therapy here again, because it's much more potent at LDL lowering. And we know that there is a inverse dose dependent relationship between LDL and adverse cardiovascular events. So the lower you get that LDL, the fewer major adverse cardiovascular events you're going to have. Now, people, especially in the era of these multiple agents lipid lowering therapy, worry about the LDL cholesterol being too low. And that's often a concern I hear from many of my primary care and internal medicine colleagues that ask me, well, isn't it dangerous? The fear of low LDL comes really from early trials, from the cholesterol treatment trialists, where we saw maybe a slightly higher hemorrhagic stroke signal in statin treated patients in that meta-analysis. But here's the caveat. That was a meta-analysis. You're lumping people from different types of groups. You're lumping many different patients together and making conclusions about causality from that meta-analysis can sometimes be a little bit tricky. In fact, subsequent analyses where trials such as the Fourier trial, as well as the Odyssey outcome trials, which are trials of PCSK9 monoclonal antibody inhibitors that really drop down that LDL. We're talking median values in the upper 20s, have shown that to be extremely safe with respect to all types of major adverse cardiovascular events. And so I feel very comfortable from a physiologic standpoint, lowering the LDL. And as we've talked about before, the central nervous system has the capacity to synthesize its own LDL cholesterol as well. Now, talking about the neurocognitive effects of lowering your LDL very much, we have data there too from the Ebbinghaus study, which was a neurocognitive analysis of patients in the Fourier trial, which was a trial of evolocumab with very low LDLs, LDLs in the upper 20s. Some of them even got down into the 10s or teens for their LDLs. And they were followed for 2 years with formal neurocognitive testing. And here again, we found very reassuring signals of no significant differences in neurocognitive endpoints. So as a cardiologist, I think less endotoxin, lower them aggressively, reduce their risk. It's one of the few things in cardiology where we see that inverse dose dependent relationship. The more you lower it, the more you're going to reduce their risk and feel comfortable doing so. Now, I don't willy-nilly drive people down into the teens if there's not a good reason. But if they're high risk phenotype, whether it's high risk primary prevention or it's secondary prevention, then I do feel very comfortable doing so. I would say that we have a blindfold on when it comes to treating LDL cholesterol, which is so challenging, right? It's already a challenging condition to treat because it's asymptomatic. So patients don't complain about it. They don't come to your office and say, I've got hyperlipidemia. They will come and tell you about their back pain or their urine infection or knee pain or whatever else they might have. So it behooves us to look. And in fact, data from the Gould Registry and others tell us that some of us check lipids in fewer than 10% of the patients annually, the secondary prevention patients that we really ought to be looking at on a much more regular basis. So I would say as clinicians, in order to improve outcomes, one of the first things that we can do is take that blindfold off. Take that blindfold off and get a feel of the pulse of what that LDL is doing and check it on a regular basis so that you really have a sense of what that trajectory looks like. The other thing I would add is that you want to iterate the target at every visit. So don't just put somebody in a box less than 70, a box less than 55, and leave them there. Every time you see them, you need to reassess which box they go in for their LDL threshold because a clinical event could have occurred. They could have developed CKD. They could have started smoking. They could have had another stroke. They could have developed diabetes. Something could have occurred that has now changed that LDL threshold to a different box. So don't get complacent with just sort of keeping them where they always were. Every time you see them, you need to do it. And the way that I can incorporate prevention as a preventive cardiologist into every single one of my visits is I take the last 2 or 3 minutes of every visit, no matter what it's for, to take a quick look at that LDL cholesterol. Because if you think about the population attributable risk, lipids has more of an impact on your cardiovascular risk than smoking, than diabetes, than obesity, than sedentary behavior. So, in terms of how much bang for your buck you're going to get by changing people's population health, modifying disease, not just for an individual, but on a population level, it's going to be, if you take those few minutes at the end of the visit to look at that LDL, to really be thoughtful about where you want this patient to be, and then make sure you check those numbers in order to get them there more quickly.